Parapharyngeal space is also known as the lateral pharyngeal space or the pharyngomaxillary space. It is an inverted cone with its base bounded by the petrous portion of the temporal bone and its apex lying at the level of the hyoid. Its boundaries are: it is divided into two compartments by the aponeurosis of zooxanthellae and tested, the pre-styloid compartment and the post-styloid compartment, which are named according to their position relative to the styloid process. Before we go into the compartment, first we will talk about the boundaries. Now, superiorly it is limited by the skull base. Inferiorly it forms the apex at the hyoid bone. Posteriorly it is lined by cervical vertebra and the paravertebral muscle. Anteriorly by the pterygomandibular raphe. Laterally by the mandibular ramus, parotid deep lobe medial pterygoid muscle, and medially by the oropharynx and the nasopharynx. You can see over here in this picture, this here is the parapharyngeal space. You can see how medially it is lined by the oropharynx and the nasopharynx over here. And laterally lies the ramus of the mandible, medial pterygoid muscle, the parotid gland over here. Now, as I was telling you, it is divided into two compartments by the aponeurosis of zooxanthellae and tested, the pre-styloid and the post-styloid compartment. This is in accordance with its position relative to the styloid process. So, the pre-styloid compartment, it contains fat, connective tissue, maxillary artery, inferior alveolar nerve, lingual nerve, auriculotemporal nerve, and the deep parotid lobe. This is the pre-styloid compartment. And the post-styloid compartment contains the carotid sheath and its contents, the 9th, 10th, 11th, 12th cranial nerve, sympathetic chain, and associated lymph nodes. So, this area here, right over here, is the parapharyngeal space and how it can be divided into pre-styloid and post-styloid compartments. It communicates with other spaces too, that is the retropharyngeal space, the submandibular, parotid and the carotid, and also the visceral spaces. Parapharyngeal abscess. Now, in case of parapharyngeal abscess, the source of infection can be multiple. It can occur from the pharynx, like acute and chronic infections of the tonsils, the adenoids, the bursting of peritonsillar abscess, because the peritonsillar space communicates with the parapharyngeal space. It can also occur from dental infections, mostly from the lower last molar tooth. It can come from ear causes like basalt abscess and petrositis. Other spaces like infections of the parotid space, the retropharyngeal space, submaxillary spaces, or it can also occur from external trauma like penetrating injuries of the neck, injection of local anesthetic for tonsillectomy, or mandibular nerve block. Now, coming to clinical features, the clinical features will be dependent on the compartment which is involved. As I said earlier about, there are two compartments, the pre-styloid and the post-styloid compartment. So, the difference in clinical features will arise due to the anatomical contents of these subspaces. So, the anterior compartment contains fat which in the presence of infection may liquefy, develop into pus and hence lead to abscess formation. Whereas the posterior compartment is actually rich in lymph nodes and vessels, and this it is suggested the infection in this space will cause lymphadenitis but is less likely to develop into abscesses. Now, coming to the anterior compartment infections, they will give you a triad of symptoms which includes prolapse of the tonsil and the tonsillar fossa, trismus due to spasm of the medial pterygoid muscle, and an external swelling behind the angle of the jaw. There can also be marked odynophagia associated with it. Coming to posterior compartment, the posterior compartment involvement will produce a bulge of the pharynx behind the posterior pillar, paralysis of the 9th, 10th, 11th and 12th nerve and also the sympathetic chain, and swelling of the parotid region. There will be very minimal trismus or tonsillar prolapse. And in both the compartments, you will see common feature of fever, odynophagia, sore throat, torticollis due to spasm of prevertebral muscles, and signs of toxemia. Now, how will you diagnose these cases? So, in case of diagnosis, contrast enhanced CT scan of the neck will reveal the extent of the lesion, and magnetic resonance arteriography will be useful if there is a thrombosis of the internal jugular vein or aneurysm of the internal carotid artery is being suspected. Now, moving on to treatment of these cases. First, we have to use systemic antibiotics. This will be very necessary to combat the infection. Antibiotics should be able to affect both aerobic as well as anaerobic organisms. So, the most common antibiotics useful for these are the amoxicillin clavulanic acid, imipenem or meropenem, along with clindamycin or metronidazole to have an anaerobic coverage. Gentamicin will be useful for gram-negative bacteria. The sensitivity of an antibiotic should determine the selection of the sensitivity of the pus will be determining the selection of the antibiotic. Next, coming to the more important part is the drainage of the abscess. This should be done under general anesthesia. If there is marked trismus, a pre-operative tracheostomy will become mandatory. Now, what is the incision that you will be giving for a parapharyngeal abscess? A horizontal incision is made 2 to 3 cm below the angle of the mandible. Blunt dissection is made along the inner surface of the medial pterygoid muscle towards the styloid process, and the abscess is evacuated. We place a drain, and transoral drainage should never be done because of the danger of injury to the great vessels which pass through this space. So, both anterior and posterior compartment infections will have different clinical courses, and they will be managed differently with a more conservative approach in the posterior compartment and more aggressive surgical drainage of pus required for the anterior compartment. Now, what happens if the case has not been adequately treated? What will develop is complications. So, the complications include acute edema of larynx leading to respiratory obstruction. So, in these cases, you will have to end up doing a tracheostomy. There can be thrombophlebitis of the jugular vein with septicemia. There can be spread of infection of the retropharyngeal space. There can be spread of infection to the mediastinum along the carotid space. There can be a mycotic aneurysm of the carotid artery from weakening of its wall by purulent material. It may involve the common or the internal carotid artery. There can be a carotid blowout with massive hemorrhage. And lastly, it can lead to an acute pharyngeal perforation secondary to cervical necrotizing fasciitis.